Hello, this is Professor David Bishai, and this is part C of our lecture on healthcare labor supply, where we focus on nursing labor supply. What I want to cover in this segment is to talk about recent trends and theories about nursing labor supply and their wages. This is a graph showing nursing labor supply fluctuating between 1973 and 2009. These are young nurses that are just starting their careers, and they're mostly American trained. However, immigrant nurses might be included in this. And what you can see in the graph is large fluctuations between 100 and 200,000 nurses in the U.S. During the 1990s, as you can see, there was a nursing shortage, and efforts began over 20 years ago to try to correct that shortage using market mechanisms. So there's been a lot of work on theories to try to explain nursing supply and correct shortages and try to get the American workforce up to the numbers that we need. America's getting older, and we're facing new chronic health challenges and a new population that can really take advantage of many more nurses than we've had in the past. So let me go through some of the things that the economics of nursing labor supply has had to deal with. They've really wanted to try to explain nursing shortages and try to find out why wages are not really equilibrating and solving this. Because in other labor markets, if there's a shortage with a certain type of labor, wages just go up and fix it. So here are the theories we're going to cover in this section. First, a theory that monopsony hospitals are depressing nursing wages and trying to hold down nursing wages, and that might lead to perpetual shortages. We'll go over that theory and perhaps just not accept it, because nurses do seem to be overpaid relative to other similar well-trained professionals. And there are many non-hospital employers that can hire nurses that do not have monopsony powers. This is not a very promising theory, but I wanted to show it to you in just a minute. Another theory for why the labor supply might be so low might be a small pipeline. Theories that we don't have enough nursing professors, and that might have been true back in the crisis time of the 90s, but I'll show you new data on that. Third theory we'll go over is yuck factor. What that means is the theory of compensating variations, where nursing is demanding, has working conditions that might not be attractive to most people, and that difficulty of dealing with those demanding working conditions might depress entry and might lead to shortages of people in this field. The final theory is one called the vocation devotion theory, where there's a limited supply of the best nurses, and that might constrain hospitals and healthcare settings' ability to attract nurses. So let's start with monopsony theory. This should be relatively straightforward. If we do believe that hospitals have some type of market power and concentration in many markets, and in rural areas they really do, then that monopsony buyer would lead to hospitals, quote unquote, saying they are understaffed in order to depress their own demand for nursing and drive down their wages. This would be a theory that implies that nurses would be underpaid relative to the next best use of their human capital. It would show that the price paid by the monopsony buyer would be less than the perfectly competitive equilibrium. You can go back over your notes about how monopsonies work to confirm that. Now, this is not a great theory, because the data are going to show that nurses are actually overpaid. Part of that overpayment is partly because of this compensating variations for the unpleasant features of life as a professional nurse. But part of the reason nurses are overpaid remains unexplained, and we need a theory of why nurses are overpaid rather than a theory of why their wages might be depressed. Let me show you some of the best evidence on the theory of whether there can be monopsony pressure downward on nurses' wages. Nursing wages are shown in this graph in the purple histogram. So we've taken data from markets all across America and looked at the lowest paid nurse earning, looks like about $5 an hour, up to highest paid nurses making upwards of $120 an hour, with this long right tail of extremely high-paid nurses. The blue curve is a group of college graduates that are of the same age profile that can be regarded as comparable to nurses. We obviously can't compare bachelor's degree nurses to anybody. We have to compare them to a demographically comparable group. And if you see overall, the unadjusted wage gap, which is what I'm showing you in this graph, is about $6 between the median RN and the median in the college comparison group. Hirsch and Schumacher, who did this study, redid these curves, starting to adjust for job attributes, both job prestige and labor statistics about how pleasant or unpleasant different jobs were rated by the people who did those jobs. If the job exposed you to personal risk of death or disease, or if the job exposed you to unpleasant smells or working conditions, these job attributes were rated, and then these economists adjusted for these job attributes, and that got rid of a lot of the gap. It got rid of $4.21 of the gap. So part of the reason nurses are indeed overpaid is because they need to be overpaid to deal with the unpleasant job attributes. But there's another $2 of overpayment for nurses that is unexplainable, and certainly if there was monopsony, depression of their wages, we wouldn't be seeing that type of an overpayment for nursing salaries. So the second theory to bring up is pipeline theory. Back in the past, in the 90s, there was a shortage of nursing instructors that was part of a syndrome with high tuitions and full classrooms and nursing applicants being turned away. However, as part of the correction for that past shortage, there's been an increase in nursing programs, and if I show you this graph, you'll see that after 2004, this is the red curve showing the number of U.S. first-time graduates taking the nursing qualifying exam, the NCLEX exam. So after 2004, we see a regular uptrend in the annual number of test takers entering the career of nursing, or at least trying to enter it. Because after 2012, something happened, and there was an increased number of test takers that didn't pass the test. One theory is they just were not as well prepared starting suddenly in 2012. Perhaps they started to party too much and just didn't study for their exam. I doubt it. I really think that what happened in 2012 was that the nursing profession's gatekeepers adjusted upward the passing grade on the NCLEX exam, creating this need to tighten the screws on entry into the market. In a way, tightening the screws on entry into the market after 2012. I wish I had the latest data on passing rates for the NCLEX exam. Certainly if you have friends who are in nursing school, they would like to know if the test has remained just as hard to pass. But in terms of there being a shortage of positions in nursing schools, that does not appear to be the case. And some of these test takers obviously would also be nurses from foreign countries that have decided to migrate to the U.S. to start their careers here. There are other reasons that the pipeline theory is not very satisfying as an explanation for nursing markets today. One really important fact is that work as a nurse is still very gendered in the U.S., and nurses have been and remain majority female. And many young women who go into the nursing career will have to have a life course that has to juggle both their work as full-time nurses as well as raising a family. Some, not all, not even most, decide that they would perhaps take time out of their nursing career to focus on their families and children, and then re-enter the nursing labor force. So that reservoir of nurses who are temporarily staying out of the labor market can help the nursing labor supply equilibrate. If there is an upward tick in the wages, the nurses would re-enter. If the spouse loses a job or if the children leave the nest, there would be a lot of nurses that can come back in. And the other reservoir for nursing labor supply is a pool of international immigrant nurses who in the past have come to the U.S., and if there are future labor shortages, then one might expect that immigrant pool to increase again. Let's move on to this idea of compensating variations. As you know from your other study of labor markets, jobs that are not so pleasant will have to start paying higher wages to attract job entrants. People just don't like to do things that are unpleasant, and so if you pay them more and more, then they'll overcome their resistance. In nursing, there are body fluids and demanding patients and families that can be difficult to deal with. There's also the problem of workplace autonomy. As a professional nurse, you are, by law, forced to always ask somebody else for permission to do stuff. And in some settings, the people you ask permission for are physicians or other members of a hierarchy. And that can be hard to take for modern workers who really value their autonomy and their ability to make choices and decisions on the job. There's social prestige that's very, very important to try to make up for those repelling factors. And there's this warm glow surrounding this profession, a warm glow that nurses also participate in. The feeling of making a difference in somebody's life attracts so many nurses into the profession. Now, I want to go back over what that's valued at, as I showed you just a minute ago. The unadjusted wage gap was $6.23. The adjusted wage gap was $2.02. So the compensating variation seems to be worth about $4.21 an hour in wages, and that's a lot of money over the course of a year. It would be worth about $8,000 to $10,000 in a year of payment to put up with the unattractive features of a nursing profession, balanced by the warm glow, balanced by whatever positive social value one derives from being a nurse. The last point is this theory of vocation devotion theory, market signaling that says I am a worker that is driven by something more than profit. If you can tell your boss that you want to participate in being a caring Hopkins nurse, and if you click on this link on your own PowerPoint version of these slides, you'll see a video of a nurse who works for Johns Hopkins Hospital saying that it gives her an identity to work for a hospital that's highly rated as a high-quality hospital. Now, it's well known that Johns Hopkins Hospital pays a little bit less than the city's market average wage per hour. So Johns Hopkins is offering a different sort of compensating variation. It says if you work for one of the best hospitals in America, great, we'd love to have you, and because you love that cachet of working for Hopkins, we don't have to pay you so much. That, as a strategy for Hopkins, gets them to have a different sort of worker, a worker who is motivated by the prestige of Johns Hopkins. We expect that type of a worker will perhaps be a more caring, more industrious nurse and offer additional benefits to the hospital in terms of quality of care. Now, they could be scarce, and this idea that there will be lots of hospitals like Johns Hopkins that are depressing the wages to try to cream skim and get these highly devoted nurses, that might not depress wages overall. But that theory is out there, and it might be something you might find useful in the future, where instead of paying the top dollar for the best type of employee, you realize that the best employees are motivated by something that isn't money. You offer them less money and you get more of them. Paradoxical, but it might be true in this very rarefied market for caring and devoted nurses. So let's summarize what we've gone over. When we talked about physician supply, we talked about whether or not the physician optimizes profit, and we put out the theory that the physician maximizes a utility function that only includes profit as one of the objectives, also includes leisure time, also includes patient outcomes. So we know that they're maximizing some complex combination. Different physicians would maximize different pieces of this to different degree. We talked about cost functions, and I emphasized how important it is to pay attention to what the agent is minimizing and whether they are actually minimizing costs when we look at data from the real world about cost and expenses, because not all expenses are actually minimum costs. There's many wasteful expenses out in the world of data. In nursing supply, we talked about this problem of shortages as well as wages. We've rejected the monopsony theory of nursing labor markets. We've seen that the pipeline can be a problem. Nursing professors have been scarce, but now it doesn't seem to matter as much anymore. The nursing entrants have been increasing over time. The compensating variation story is part of nursing wages, and we've given an estimate that it amounts to about $4.21 an hour of extra pay to compensate nurses for the unpleasant aspects of their career. Raised the final issue of vocation devotion theory as something of interest that might be happening in elite markets for nurses in academic health centers, where they could be attracted by the name and the branding of the hospital where they might be working. Well, that's been a lot. I thank you for your patience, and we'll look forward to talking about more in our next lecture.